Yet another DMA NDB meet. So this is our 77th consecutive meet. And we have with us our guest speaker, Dr. Nidhi. She's no longer a guest, of course. She's been taking over these sessions very efficiently, and much to everyone's surprise, we are all learning a great deal about a lot of topics. So we have chosen another series of inflammation now. So today is the second episode of the inflammation. Along with this, we will be doing the usual COVID update and some more pointers about the vaccination. So without much delay, I would request Dr. Nidhi Dhawan, who is the Associate Medical Director of ENT and the head of the Safety Committee in Shroff Charity Eye Hospital in Daryaganj, to come forward and take over the session. Over to you, Dr. Nidhi.
Thank you so much, Dr. Meenakshi. So, as usual, we will start with the COVID update and move on to inflammation. Specifically, today I wanted to address basic definition and how it relates to COVID. So we will be discussing mast cell activation today. And then we will also take up vaccinations and some important things that we want to address in vaccination. We had a question from one of our audience about what they can do if they're fully vaccinated. So we'll go into that also. So today is 7th of November. It's nearly 2 years now that we've been dealing with COVID. And these 2 years have been really a journey back to basics, going back to molecular biology, going back to immune pathology, and moving away from treating diseases to treating chemistry. Also, it has been 2 years of evolving epidemiologic approach to a disease which has ravaged the whole globe. So as of May 28th, that was when we were in our almost hitting our peak. We went up to 4 lakh cases a day, to November 5th, where India is less than 15,000 cases a day and progressively becoming less. So we had started October with around 28,000, and we are in November going more towards 10,000. Interestingly, we are seeing different areas of the globe peaking at different times, and we'll go into that a little later. But seeing the evolution, if you see that in June it was Brazil on top, in August, in May we were on top, June Brazil, August United States, and then United States stayed there till October, November. And US still has about 75,000 cases, though now their daily numbers are falling somewhat below their rolling 7-day average. India in May was at 4 lakh plus. And if we see in August, and then in September, and then in October, we have been progressively going from nearly 40,000 to 30,000 to 15,000 to 13,000 and now 12,000. So we are showing a progressively downward trajectory. And each week, our daily cases are less than the 7-day rolling average, which means that the trend is downward. The daily new confirmed cases as per our world in data in October, you see the UK, parts of Mongolia, little bit in Middle East, US. These are all dark, nearly 1,000 per million. And if you look at 5th of November, UK is still dark. Middle East and Europe is expanding a little bit. Mongolia is clearing up. But look at the difference between India. India is becoming lighter and lighter with every passing week. So if we see the cumulative cases and the cumulative deaths, and now these are all statistical data that point to a certain pathologic trait of the population. So if we look at the cumulative confirmed COVID cases, we see United States right there on the top. We see India fairly close second, Brazil, United Kingdom, the top 4 countries. And you see everybody else is clustered somewhere near the baseline, including Ethiopia, which doesn't have very good vaccine coverage, including Israel, which has absolutely fantastic vaccine coverage, and China, which has a very good vaccine coverage. So the common thing between these 4 countries seems to be a relatively healthy population without markers for chronic inflammation. But we'll go into that also. And if you see, United States, the obesity capital of the world, Brazil, the obesity capital of the world, India, the diabetes capital of the world, UK also has fair amount of chronic inflammation in its population. These are the countries which are having more mortality. However, you look at where India is in terms of cumulative cases, and you see where India is in terms of cumulative deaths. So, larger the inflammatory burden in the population, worse is the disease outcome globally. And we can see here how it has changed over the last week or 10 days again. Similarly, now United States had begun showing downtrend. India significantly downtrend. Brazil kind of flattening out. UK still not very flat, and we'll see the graphs later. UK graphs are paralleling Kerala graphs. China, even though we are hearing, is again in the midst of lockdowns. We don't have much detail about what is happening in China and what variant they're seeing. The bi-weekly change, if you see, and this is what I was referring to, US minus 9%, UK minus 9%, China 179% plus, nearly 200% plus. Russia 21% plus. India nearly 20% minus. Brazil 7% minus. Most of this appears to be Delta driven. And our recent sero surveys say that we may have achieved 70 to 80% sero prevalence with Delta, which means that we may have better immunity, but the coming 2 weeks are the weeks to watch for. So if we look at vaccination, India has the least in the top 4. No, Russia. Russia has very poor vaccine uptake. There is very little confidence the population has on vaccines in Russia. So US, per 100 people, they have about 130 doses. UK tops the list with 160 doses per 100, which means that you can say if 2 vaccines are needed per population. So 100% of the population has been covered by at least one dose, and about 60% of the population has also received the second dose. In Russia, the coverage is less than 100%, so the entire population is not covered. Same with us in India. Our coverage is 77%, so we haven't yet covered the entire population with at least one dose. The total doses administered, China and India, per force of their population, are right on top with more than 5 million vaccine doses given. And if you see US, which is at 130 doses per 100, has given only 1 million. So it's 20% of the vaccines that we have already done. Brazil at 670,000, UK at 350,000, Australia at nearly 200,000, Ethiopia less than 100,000. And Israel, well, doesn't need to now, but these are 7-day averages. So now they're kind of letting up on their vaccination drive. As I said, the share of people who've received at least one dose, India is lagging behind. That's probably because we have huge numbers. So this is the line of the world. We are kind of crossing 50%. China is on top. UK, Brazil, Australia closely following. And given the fact that Australia started very late, this is really commendable. Share of population. So you see China is dark green, nearly 80 to 90%. Canada, US, Brazil, Mongolia, part of Europe. These are the areas which have very good coverage. India is still around 40%. That green is still around 40%. The share of tests that return positive. Now this is probably not a very good indicator to check because it also depends on the number of tests done. But we are hovering around 1.1%, whereas US is hovering around 10%, Mongolia around 20%. We have no data from China, and parts of Europe are going at more than 50%, which is a bummer. Case fatality rate, we are comfortably placed somewhere at the bottom of the chart. China, well, we don't know, but around 5%. Brazil, Ethiopia, US, UK, all of them around 1.5 to 1.7%. Vaccinations have gone well for us in the last month or so, a month and a half. Now we will see lesser number of vaccines being delivered because now people are going to be waiting for their second dose. Probably it is time for the government to take a call on reducing the interval between vaccines. And also, I'm going to make a controversial statement here, but people are talking about boosters, and I would suggest against it, at least in the present scenario. So and we'll discuss why I'm saying that. In India, Indian government releases more than 800,000 tests have been tested in last 24 hours. And with that kind of testing, we are hovering around 1% positivity. So if you look at the shape of the graph, US, India, and the world kind of have a similar shape. And we are now at, as of 5th November, according to the Johns Hopkins site, we have about 10,900, 11,000 cases, again, which is less than the 7-day rolling average of 12,000 cases. As of 1st of November, because the COVID-19 India.org had said that they are going to stop working from 31st of October, and I just took a chance and saw whether they're still reporting or not, because this kind of reports, detailed reports about India, are not available anywhere else. So it's something that we need to reach out to them that they shouldn't stop. But if we look at the COVID India data, about 55% of the population is partly vaccinated. Nearly 25% is fully vaccinated. There is a downward trend in the number of confirmed cases, but there is a slight upward trend in terms of active cases. And recoveries are going down. Deceased, definitely there is a downtrend. The 4 states that we like to follow, Maharashtra is showing an uptrend in both active and confirmed cases, and a downtrend in both recovered and deceased. It is closely following national averages of around 55% fully covered and around 25% partly covered vaccination. Their active ratio and test positivity rates are right now quite comfortable, and their daily numbers are still less than the 7-day rolling averages. Delhi, again, you see the confirmed cases going slightly up, which is to be watched. We are behind national we are ahead of national average at about 40% fully vaccinated and around 65% partly vaccinated. Especially with Diwali, the kind of pictures that I saw, and I have maintained that I am still not ready for the post-pandemic life. Maybe it is just me, but I think we need to be very, very careful over the next 15 days and watch the trends, because this trend of that upward curve is to be watched. At present, we are saying active ratio for every 10 confirmed cases, 100 confirmed cases is 0%, which means it's negligible. Positivity ratio 0.1%. If you look at Maharashtra, it is 1%. And that's also, if you look at the number of tests done, this is 6 crore. And look at Delhi, it is 2 crores. So it's we are comparing the wrong way, but given the populations, the state of testing, and the government response, these are the states that are an area of focus right now. Uttar Pradesh, if you remember, last time had gone down to single digit, but now it is again active cases around 107. But the trends are still downward with new confirmations and still in single digits. So it is showing a little bit of chronicity, which is to be watched for. Active ratio again 0%, test positivity ratio again 0%, and over here we are talking about 8 crore tests, nearly 8.5 crore tests. So it's not as if there is less testing in Uttar Pradesh. With the same amount of testing, with less vaccine coverage, at least 1 dose 40%, and fully vaccinated only 14%. So Uttar Pradesh has, despite these negatives, managed to have very good performance, perhaps because of their universal ivermectin coverage. Kerala, now look at Kerala. Highest active ratio, highest test positivity ratio. Not so many tests, They are testing around Delhi's numbers, not even around Uttar Pradesh or Maharashtra numbers. Their population is also much less than Uttar Pradesh. Their vaccine coverage is much more. They're ahead of national averages with 72% partly vaccinated and about 40%, and national average is 25%, 40% fully vaccinated. Now look at Uttar Pradesh, 14% fully vaccinated, 45% partly vaccinated. Look at Kerala. Despite that, their test positivity ratio is 10.5%. All these are very important to watch. Now, Kerala's graph follows UK graph. The country which is doing a lot of tests. Kerala's graph is something like this. It's just not falling to the baseline. Now, you could say that that is because of increased testing. But if we look at Uttar Pradesh and Maharashtra, they have tested more than Kerala. That's not the only reason why this could be happening. If you look at the US graph, you see two clear peaks. You see that they're not quite going down like the global numbers, but you see two clear peaks and you see that it is kind of touching the baseline, but not quite. So US, India, and the globe sort of follow similar graphs. Russian graph is on the up trend. And if you see, it's kind of 7-day averages and new cases are kind of balancing out, but not quite. They're slightly ahead. So 39,617 new cases, but the 7-day rolling average is 39,200. So this is not coming down in the coming 2 weeks. This is only going to show upward trend in the coming 2 weeks. So given that UK has the highest testing in the world, highest genomic sequencing in the world, and the most stringent government response in the world, apart perhaps from Australia, if you see, UK has started showing a significant trend towards becoming less. From 37,500 7-day average, we are at 33,600 new cases a day. So this is a trend similar to India, where the new cases are less than the 7-day average. So the Zoe symptom tracker, despite the government not giving out figures which explain these graphs and numbers, the Zoe symptom tracker, which is parallel to like our COVID19india.org, where people can report their own symptoms, they have been seeing that we may have broken the back of COVID and that the pandemic may be on its exit now. Now, why we are saying maybe? Because if a new variant emerges, we are all brought back to the Delta days, and the way to deal with it is going to be going back to the drawing board and not boosting with existing vaccines. Again, I'm going to come back to it when we talk about vaccinations. So have we beaten it yet? And what is the next big question if we have beaten it? If we have beaten it, the next big question comes, what about long COVID or the disease burden of chronic inflammation? That's why going back to the drawing board and studying inflammation becomes important. So what could be causing long COVID? Initially, people thought that it could be persistent viremia. They also thought that, particle fragments of the virus could be causing persistent inflammation or an overactive immune system. Even autoimmunity was thought to be driving it. But all of these, persistent viremia, persistent viral debris, overactive immune system, and autoimmunity need our body's defenses to work in a certain way. And the cellular basis was thought to be perhaps driven by inappropriated mast cell activation and resultant MCAS, mast cell activation syndrome. Also, it was seen to be associated with dysautonomia, metabolic syndrome, and yes, microclotting. So, when Sir used to say that you have to start blood thinners early and continue them as long as possible, he was matlab unki foresight somewhere early in the pandemic he said this, but unki foresight needs to be lauded. Now it is a combination of several factors, and we are looking at 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 factors here, and a combination of any of the 10. So it can be persistent viremia with autoimmunity, or persistent viremia with overactive immune system, or persistent viremia with microclotting, and each combination can result in a different pathogenesis, which results in similar clinical picture. So what are the targets on the inflammatory pathway that we can address so that we can deal with long COVID and persistent inflammation? So what really is inflammation? Inflammation is any tissue damage which initiates some vascular and cellular events, and these vascular and cellular events help to repair the damage induced by those triggers. The trigger can be it can be trauma, it can be infection, it can be any of those things which causes even some chronic inflammatory diseases like disordered metabolism, high blood pressure. All of these can result in, or dyslipidemia can result in tissue damage. Now, whenever there is a damage in the body's tissue, the body's tendency is towards homeostasis, towards establishing a new balance. And these events that come into play will try to repair the damage and clean up the waste that is produced by this inflammation. So inflammation is mediated in the short term by histamine, leukotrienes, plus prostaglandins, and by bradykinins and fibrin. The arachidonic acid that is acted upon by lipooxygenase and cyclooxygenase 1 and 2 is what causes the downward cascade into both innate immune response as well as complement mediated immune response. These two cascades then educate the body as to what it needs to do, how soon it needs to respond towards an adaptive immune response. The selectins from preformed granules in mast cells open up the intercellular spaces, causing leakage of fluid into the interstitial space where edema sets in. So that's the first sign of inflammation. As the interstitial space expands and the trigger towards migration of neutrophils and mast cells and macrophages happens, the rest of the things, apoptosis, pyroptosis, local heat, congestion, all those signs also set in. Basically, we have to look at the antigen presentation by B lymphocytes, dendritic cells, and macrophages in infective pathologies. And we have to look at macrophages and mast cells in non-infective pathologies. So what does mast cell do? Mast cell has some chemical mediators that it immediately degranulates. It releases histamine, prostaglandin, D2, tryptase, and heparin. The disorders that can be triggered by inappropriate mast cell activation could be primary, which is by abnormal production and stimulation of inappropriate mast cells. It could be secondary to some triggers. MCAS has been seen in other viral diseases also, including Zika. Sir was asking about Zika, so it has been seen in Zika also. Or it could be idiopathic when we cannot figure out what is really happening. So this is the connector perhaps between the acute and post-acute phase of COVID and the long drawn-out chronic COVID. When we say that mast cells cause a certain clinical picture, what are we looking at? Again, going back to what Dr. Agarwal used to tell us, kuch Ayurved mein bhi diya gaya hai organs, and I'm not a master of those things, but he used to talk about skin, GI, neurology, respiratory, and cardiovascular system. He used to add the eyes to this. And we will see that eyes are a part of the mast cell activation syndrome clinical picture. So the diagnostic criteria given by WHO are that at least 2 of these 5 systems should be involved at any given time. There may be periods where there are no symptoms. The symptoms can range from urticaria, angioedema, congestion and flushing of the skin, nausea, vomiting, diarrhea, and abdominal cramps for the GI system, hypotension, syncopal attacks, and tachycardia. Now, this is important. Tachycardia for the cardiovascular system, wheeze, nasal stuffiness for the respiratory system, pruritus generalized as a sign of histamine overactivity, conjunctival congestion, as I was telling you, sir kaha karte the ke eyes bhi hain, though the WHO criteria of organ systems does not include eyes. Now, all these symptoms must respond to treatment with antihistaminics, anti-leukotrienes, or mast cell stabilizers, singly or in combination, for it to be called mast cell activation syndrome. So what are the mast cell stabilizers that we can use? I am quite partial to loratadine. I like loratadine more than I like cetirizine even. But the reason why loratadine works better, even in mild allergies, is because not only it is an antihistaminic, it is also a mast cell stabilizer. Chromoglycolate eye drops used to come, which we still use in chronic persistent allergic rhinitis for stabilizing mast cells as nose drops. So these are olopatadine and ropatadine are again combination H1, H2 as well as mast cell stabilizing agents. So of late, and this is an article from, if I'm not mistaken, 2021 September. So of late, there has been an explosion of research into mast cell activation disorders and what they call mastocytosis or mast cell proliferation in increased numbers in peripheral smears. The labs that we can use to diagnose mast cell activation syndrome are validated urinary or serum markers with documentation of an increase above patient's baseline on more than 2 occasions during symptomatic phases. Now, why this is important is because in the asymptomatic phase, the patient may have absolutely normal chemistry. So testing him when he's not having symptoms is going to give us no diagnostic information. Baseline serum tryptase persistently more than 15 nanograms per ml is one of the diagnostic tests that can work even in the asymptomatic phase. But you would need at least 2 or 3 readings which show persistence of tryptase more than 15 nanograms. If you are able to show an increase of serum tryptase over the baseline on even one occasion, it is considered diagnostic. 24-hour urine assay of histamine and its metabolites, of PGD2 and its metabolites, or of 11-beta prostaglandin and F2 alpha are again considered diagnostic. What are the clinical picture that you may see in MCAS syndromes? Now, there are three overlapping clinical syndromes. The hypermobile Ehlers-Danlos syndrome, postural orthostatic tachycardia syndrome, and MCAS. Common to all of these is weakness, fatigue, abdominal pain, nausea, vomiting, diarrhea, bloating or constipation, hypotension, exercise-induced fatigue and intolerance, impaired cognition and fogginess, headaches and palpitations. Do you see what this is? This is also the picture of long COVID. Now, what is common between MCAS and hypermobile Ehlers-Danlos is heartburn and gastric reflux. What is common between MCAS and POTS is chest pain and fogginess. What's common between POTS and Ehlers-Danlos is dizziness, sleep disturbance, and orthostatic intolerance. So we are seeing a constellation of symptoms which can easily be explained by inappropriate, overstimulated MCAS. And if you go a little deeper, under one layer only, you see that hydroxychloroquine has been proposed and validated as an approach, a therapeutic approach to treat mast cell activation. So it's again, I think Sir needs to be saluted. He had foresight that is now getting validated. Now, if we look at the clinical picture and we assume that we have a lot of patients who come to us with unexplained vertigo and tinnitus, I have to confess, I have never thought of MCAS in them. People who come to you with non-specific headaches and chronic fatigability. People who come to you with unexplained seasonal allergies and asthma. If you see somebody who is having palpitations and you say you have dehydration, irritable bowel syndrome and pelvic floor dysfunction. So these are all, you pick up one part and you say this is the elephant. And you miss the global picture, which could be the overlapping of so it would be good to start thinking rather than taking an over specialized specialist view, an expert view about one organ. Start treating the patient as a complete body rather than one organ. So what can cause MCAS? Anything can. Foods, chocolate, spicy food, alcohol, drugs, even non-steroidal anti-inflammatory drugs can cause MCAS. Opioids, vancomycin, some poisons and bee sting, alcohol, stress, emotions, anxiety, even exercise, changes in temperature. You see some patients classically tell you that, I start sneezing when it becomes cold. And traditionally, I have tried to explain it by saying that the spores and the pollen settles closer as it becomes cold. But educational, even me, it could be MCAS. Surgery, vaccines. Again, something that we have to so Mast is triggered, triggers of the complement system. It binds with IgE, cross linkage of two IgE antibodies, and causes degranulation of the mast cell, which releases tryptase, histamine, heparin, bradykinin, leukotrienes, and notably IL-6 and TNF-alpha. Now, why this becomes important is because IL-6 and TNF-alpha, though are markers of acute inflammation, these are the triggers to chronic inflammation. The cascade going down may increase the number of mast cells or the activity of mast cells, or both. So when the mast cells into the skin, you can see rashes, big patches of pigmentation, which may be polymorphic, monomorphic, which may be diffuse, and they could be just elevated patches of bacteria. And the WHO has specific criteria. We have seen these not really considered MCAS as one of the differentials. As I said, you say that symptoms of MCAS should be 2 or more organs. You should be able to demonstrate a rise over baseline of the mediators, tryptase, histamine, prostaglandins, and leukotrienes, either in the urine or in the blood. There should be a more than 50% response to mediators, which control the controller of these mediators, that is mast cell stabilizer and antihistaminics. And there should also be perhaps absence of other diseases. This is difficult because there is so much overlap in chronic inflammation and MCAS that having this fourth criteria met is a very strict criteria. So the degranulation that occurs within seconds releases TNF-alpha, among other mediators. In minutes, icosanoids are released, and the third category of mediators, which comes about in hours, is cytokines, chemokines, and growth factors. TNF-alpha is both an acute phase response and a slightly delayed response. So TNF-alpha is significantly causing the chronicity of inflammation because that mediates the nuclear factor kappa beta pathway, which is suppressed by ivermectin. It also triggers the NLRP pathway, again, which is suppressed by ivermectin. So ivermectin is not just an antihelminthic, it's not just a horse dewormer, it is also a significant anti-inflammatory agent, which is found in the soil of Japanese coastal areas. It is a natural agent derived from a fungus found in that soil. And perhaps the reason why Japan has fared so well in the present pandemic is because they have natural analogs in their circulation. So the immune responses can be tissue and systemic inflammation, increased vascular permeability, the effector cell recruitment and mobilization of monocytes, neutrophils, dendritic cells, natural killer cells, T helper cells. So this is moving from acute phase, monocyte neutrophil, to through dendritic cell, the connector, to NK cell and helper cell, which is chronicity. Now, either this can result in clearance of the virus, or it can result in internalization of the virus in mast cells and persistence, like dengue uses this mechanism. So, as I said, TNF alpha is an important immediate as well as over the hours response, and immediately histamine causes nasal congestion, itchiness and runniness of nose and eyes. Over minutes, prostaglandins and leukotrienes kick in and cause bronchoconstriction and wheezing. And over the next few hours, these are the respiratory features of an allergic response. Something that we see in any allergic response, but will be heightened in MCAS. The mast cell activation syndrome, or MCAS, results in hypersensitive mast cells, which cause excessive release of mediators, which drive asthma and allergy in skin, GI tract, cardiovascular system, or respiratory system, which is not explained by a simple allergy. Again, I don't think I need to go much into detail here. However, this is the connector between the IL-4 mediated Th2 response when encountering an antigen, and an interferon gamma induced Th1 response when the antigen is related to pathogens. So this is allergens and this is pathogens. It can involve almost any system in the body, either singly or in combination. The various receptors, histamine is the first trigger. So histamine H1, if you see, can cause smooth muscle constriction, estrogen metabolism, derangement, increase in mucus secretion. So this can affect the gastrointestinal as well as the respiratory systems, the menstrual system, where it causes pelvic inflammatory disorder, as we saw earlier, or pelvic pain and dysmenorrhea, PMS and endometriosis. The H3 and H1 and 2 combination can work in the CNS and cause headaches, nausea, vertigo, irritability. And that is why Vertin, a beta histine antagonist, which works on both H1 and H3, it is a selective antagonist of H1 and a partial agonist of H3. So it works in vertigo and central nervous system referred effects of muscle irritability, depression, potential tachycardia. If it's on the cardiovascular system, it causes rhythm abnormalities, orthostasis, decreased circulation in the periphery and peripheral cyanosis, and tachycardia. That is the hallmark of POTS. In the skin, you know the allergic symptoms. So if you see histamine, the first trigger, can by itself explain a lot of the systemic effects of mast cell activation. But that's not the only thing which is happening. So there are so many things which are happening with inappropriate stimulation of mast cells, with allergens, bacteria, cytokines, drugs, fungal infections, even some proteins. And that is good to remember, because we are talking about protein-based vaccines now, toxins and viruses. So TNF-alpha activates the renin-angiotensin system, causing cardiovascular effects. TNF-alpha activates the symptoms. TNF-alpha works on the serotonin pathway and activates the digestive symptoms. The interleukin system, TNF-alpha on the muscular system, chronic fatigue, pain, bone pain, and then it goes to the osteoclasts. Which causes cytokine and causes activation of other effector cells, including neutrophils, eosinophils, natural killer cells, B cells, and T cells. So we have seen that the central molecule seems to be TNF-alpha, which is a marker of chronic inflammation, which is an activator of the nuclear factor kappa beta pathway, which works on almost every system in the body. TNF-alpha comes right way up on the top as a possible target, a therapeutic target for chronic inflammation and COVID-19 also. This is a slide that we have often visited, but so this one we can go into details a little later maybe, but has targets of various therapeutic agents. I'd like to now come to vaccination. Now, we are going to see vaccination from the perspective of how the immune system works. Why is vaccination needed? And yet, what are the things that we should be careful of when we vaccinate? So, immune response, we all know that when the virus attaches and enters into an antigen presenting cell, the antigen presenting cell presents this to CD4 cells, which get educated to recognize the antigen and then can be triggered towards a cell-mediated or antibody-mediated immunity, which is why just simply measuring antibody titers is not predictive of your immune status. What the vaccination strategies that we have been following for COVID have ranged from mRNA vaccines to DNA vaccines to protein fragment vaccines to whole virion inactivated or dead virus vaccines. The immune response to all of them is to recognize an antigen which is foreign to the body and to educate the body to trigger a faster response when it encounters the same next time. Why we need 2 doses of most vaccines is because the first dose primes and the second dose actually checks whether your body has been primed or not. Immune response, we have seen that can be cell mediated or antibody mediated, and antibody titers are not predictive of what your immune status is. So immune memory of natural infection, apparently people infected with SARS and MERS viruses in 2000 plus minus 3-4 years has been active even up till now, and these patients actually have a less virulent course of even COVID. There is a degree of cross reactivity between the SARS viruses, which we should be mindful of when we are talking about immunity and inflammation. Which brings me to the need for boosters. Now, people do say that the Pfizer third dose is working. People do say that the Pfizer third dose is needed. But if we are looking at data coming out of Israel and out of other places, we see that the 2003 SARS epidemic still has active immunity in patients who suffered it then. So if at all we think that boosters are needed, we have to think of boosting with things other than what has been the present vaccination strategy. If we look at vaccines, mRNA, DNA, protein fragment, all of them use spike protein as the target. The Covaxin or Sinovac use whole virion inactivated or dead virus as the trigger. If it is the, and there are studies from Salk Institute which say that the spike protein alone and by itself is capable of causing all effects of COVID-19, clinical syndrome of COVID-19. There is a recent study by some authors in Norway, I think, which tells us that the spike protein can even be internalized by the nucleus. That study, of course, is in vitro. It's not an in vivo study. And we know that the B lymphocytes really do not pick up spike protein. They are still resistant to direct infection by the virus. So that's a blessing, actually. Otherwise, we wouldn't be able to mount an antibody response. But given that, we should be looking at broader targets, or we should be looking at spike protein fragment targets, the highly conserved zones of the spike protein, which can trigger the immune response without causing the inflammatory response. So we need immunogenicity, we need reactogenicity, but we do not need the inflammatory response that comes from the spike proteins. Given that, perhaps the whole virus vaccines are slightly better candidates because they do not use the entire spike protein alone. Molnupiravir, though, has been making a lot of news. Molnupiravir specifically causes the substitution of C and G in RNA replication. So it replaces G to A and C to U in ATCG combinations. Why that becomes important is it increases mutations. And even though everybody is touting Molnupiravir, I have to ask a basic question. Why would we take a pill which increases mutations, which are unpredictable, when we have other options which are safer? So comparing the vaccine efficacy, Pfizer in elderly 94%, Moderna 86%, Johnson & Johnson 42%, and Oxford Zeneca, we don't know. The asymptomatic disease coverage, 90%, 66%, 74%, 60%. Against symptomatic disease, 95%, 94%, 72%, 79%. Now, why this is important is, if you look at MMR vaccine, 2 injections about 4 weeks apart give 97% protection against measles and rubella, 88% against mumps. If you look at flu vaccine, it gives 40% coverage, 40 to 60% coverage against influenza. It is an inactivated virus vaccine. And if you look at Pfizer and Moderna, if flu vaccine has been so easily accepted with an average of 50% efficacy, what is the problem in accepting a vaccine which is 90 to 95% effective? So there is too much polarization, too much debate, too much politicization of vaccination. If we go by the science, vaccines are effective, vaccines are protective, vaccines are not sterilizing. There is no sterilizing immunity. So it's not as if it is 100% protecting you from infection. Vaccines do have side effects. Those side effects you have to be mindful of. So there are clotting risks with AstraZeneca. There are myocarditis risks with mRNA vaccines, especially in young males. There are clotting problems with Johnson & Johnson, especially in young females. So all those factors need to be weighed in when you are recommending a vaccine. Say if you are talking about a young male between 12 to 18, as is going to be the next wave of vaccinations, avoid mRNA vaccines. If you are doing this for young girls who have achieved menarche, avoid Johnson & Johnson and AstraZeneca. But you have the other alternatives. The whole virus vaccines seem to be the safest in that. So median age
Not audible. रितु आप होस्ट है ना, तो आई थिंक डॉक्टर निधि हैज बीन लॉग्ड आउट. शी इज not there.
Okay. Ma'am, I'm calling Dr. Nidhi. Check.